Chest x-ray, the number one exam you will do as x-ray checks. You will do this in every single rotation, maybe except for OR and fluoro, but where we are, chest x-ray is your number one. It's performed to evaluate the lungs, heart, and chest wall. It's typically the first imaging test used for any shortness of breath, a cough, chest pain, or injury, and sometimes just fever. They use this exam to help diagnose or monitor treatments for pneumonia, heart failure, emphysema, lung cancer, line and tube placements, and fluid or air collection around the lungs. Body habitus is key when deciding as a technologist how you are going to place your film size. I usually call these two lengthwise or crosswise. Some people use portrait. That word doesn't work for me, but it works for you. So looking at your patient, you're going to decide, am I going to put my cassette lengthwise, this long way, or is my patient a little shorter and a little wider? I'm going to use crosswise. For the PA chest, and remember going back to our chapter 1, that means the anterior part is against the image receptor. The beam's going to enter the P and exit the A, so posterior, anterior. The patient's going to face the cassette. They're going to roll their shoulders forward and elbows away from their body. The x-ray tube is at 72 inches SID with 1 to 2 inches of light over the shoulders. That little triangle of light that I will be teaching you in lab. Okay. You're going to center to T7, and you may use this method that you've seen in your textbooks. You roll the patient's shoulders forward, moving the scapula to the lower borders, and drops the clavicles below the lung apices. An image here, you've got a left marker on the left side of the body. You can fully see the entire set of lungs from apices to angles, even on both sides. Left lateral is done routinely at the same SID, 72 inches SID. Left side closest to the imaging plate. Why? Because the heart's on the left. Bringing the heart closer to the board reduces the possibility of magnification of the heart. So you're going to make sure your patient is lateral, checking their scapular borders. You want the patient to extend their head and neck a little bit so their chin's not tucked down. Same central ray, T7. This is an example here. The patient is in lateral position. The lungs are superimposed over each other. Exposure factors. What are you going to use? This is where we use something called automatic exposure control, or your tech might use the term photo time. The wall stand that they're up against, we refer to as a wall bucky. Essentially, a bucky is something that can hold the imaging plate. It doesn't necessarily have a grid in it now with digital equipment. Most of them have a grid that slides in and out, and we will talk more about buckies and grids as we get further in here. But the PA chest tends to use the 2 outer phototiming cells at a high kVp. One of our rooms is down at 90, but most of our rooms are around 117, 120 kVp for our chest x-rays. Lateral chest is going to use only the center cell at 117 to 120 kVp. Inspiration. The patient for chest x-rays, this should be on full inspiration. Per your textbook, it should be on a second full inspiration. So how do you ask your patient to do that? Please take a nice deep breath in. Now blow it all the way out. You're going to take a second deep breath in and you're going to hold that breath. You as the technologist makes the exposure and then you tell your patient to breathe and relax. Why? We want the lungs as full as possible with air. To evaluate your degree of inspiration, and this I want you to know for your test, okay? You have to have a minimum of 10 ribs. So you're counting the posterior ribs. Does this happen on every patient? No, because sometimes your patient might be short of breath. They might be having an asthma attack. They might be having something going on. If they have fluid, there's not going to be 10 ribs for you to visualize. If you can't fix it, you just try your best. You try and communicate to that patient that you need a deep inspiration, and that's where it goes, okay? An expiration image is sometimes used to demonstrate a pneumothorax. You can see the image here on the right is less dense, right? Because the patient is breathing out. But over here, you can clearly see a pneumothorax here is compressing this lung. And we'll talk more about pneumothorax and what that is. But when is an expiration used on a chest x-ray? Demonstrate a pneumothorax. How do you know if your patient took a deep breath in? You can count 10 ribs. Rotation. This is going to be on your test. I'm going to guarantee it. It might even be on your boards. And if you're rotated, the tech is going to ask you how you know. For PA chest, if you go with me down here, you're going to look at your SC joints, and that's the sternal end of the clavicle. Okay. Sternum, clavicle connection here. Are they equal distance apart? Or is one over here in a lung field and this one's here in the spine? If they're not even apart from the vertebral body here, then your patient is rotated. On a lateral chest, do you see these posterior ribs sticking out? They make kind of little C shapes. If you see that, and they're separated like that, that means your patient is rotated. And you have to figure out which way they're rotated by going in and feeling the back of your patient and seeing if their hips are rotated or their shoulders are rotated. Penetration. This tells me whether or not I penetrated the part accurately by using correct technical factors. Right. Underexposure. See how light this is? You can't really see much detail in here. Overexposure, super dark. Stretcher chest. This happens a lot with our ER patients or our in-house patients who are unable to stand. If your patient can't stand, then we're going to do a chest x-ray in the stretcher. So instead of a PA and lateral, we will do an AP chest and a lateral. The AP is not preferred because it makes it look like there's a magnification of the heart and a widening of the mediastinum. So whenever possible, the patient should be upright and ideally PA. If they can't be PA, you want them as upright as possible for the AP. Make sure their chin is not tucked down. If they tuck their chin down, it could overlap the lung apices here. How do you evaluate your chest x-ray while looking at it? First, I always look at my anatomy, right? Over our basics. Do I have all the lungs on? Yes. Are they rotated? Remember, how do I tell on my rotation for my PA chest? I'm looking up here at my SC joints. Are they equal distant apart? Almost exact. I got a little more space here than this one, but they're not far off. My scapula, are they on lateral borders? Yep, they're moved to the outside. That means I rolled my shoulders in. How's my inspiration? Can you count 10 ribs? Equal collimation top and bottom. Do I have the patient's chin and face on? No. Is there any motion? What does motion mean? If your patient was breathing or moving during your x-ray, it's going to be fuzzy and it won't be clear like this. Exposure factors. Am I underexposed? No. Am I overexposed? Nope. I'm good to go. Do I have a left marker on the correct side and visible? Yes. Lateral chest, either in the wheelchair or in a stretcher. You'll still do up against the wall bucky. If they're in a wheelchair, that you have to take the arms off the chair, put a sponge behind them. If they're in a stretcher, you put a sponge behind them. The mattress of the stretcher shows up as an artifact, so you want to push them away from it. But same centering as if they're standing, okay? If their arms are not up high enough, as you can see in this image here with these black lines, it's showing you the arms are way down and it overlaps the lung field. So ideally, arms up and away. Do you see any rotation on either of these? Yes, this one, right? You can see the C's coming out, those posterior ribs. I don't want that. I want it to look like this, more superimposed. What do you think of this lateral chest x-ray position? I say it's junk. We've got a rotation all the way down, are also not lined up, or this is a shield here covering up the costophrenic angle. Decubitus positions, if you remember, always use a horizontal beam. So you can see my tube here. It's going to shoot across in a horizontal fashion here. Decubitus chest x-rays are done looking for fluid. And fluid in the pleural space, we call pleural effusion. Right? That's something we don't want. So anytime you get a question on a chest x-ray that's asking you to visualize the best position to visualize pleural effusion, what position would be best? Decubitus, because fluid drops, air rises. And as you can see on this image, this block right here of white is fluid. The patient's lung that's full of air is here. So this is the fluid on the side down, and it will be demonstrated on the side down is key. All right. So decubitus positions again. This is showing you how the patient's PA chest x-ray looks. See how rounded this is? There's obviously some fluid in there because there's white all the way down a costophrenic angle. It can't be clearly demonstrated until you put that patient in a decubitus position and show them the degree. Fluid's going to drop. All right, I'm going to stop there and pick up with the pathology.